I'm Chris Cook. I'm one of the screening immunisation managers at what was formerly known as the Thames Valley Area Team. I know what we're called today, but we might not be called that tomorrow, so I'm not going to go into that one. From Joe's national perspective, I'm now bringing us down to a much more local perspective and looking particularly at the children's flu immunisation programme, again, that I suspect most of you in the room have all been involved in. This is a little bit of an overview, so I'm not, apart from the data, because I like the data, we won't be going into too much detail, but I'm happy to take questions. So it is very much an overview. It's looking at things certainly from our perspective as commissioners, so we're responsible for making sure the programmes that are decided on nationally are delivered locally, that reach all our population and that are delivered safely and effectively without too much mishap and too many cold chain incidents. So just on this Cook's tour, we're going to look at just an overview of the flu programme. Very convenient name today. What makes this programme different? Because what makes the programme different actually can provide challenges to local providers in how they deliver it. But also actually, I'd like to stress, it also gives opportunities. So it's also looking at some of the opportunities that these extra work brings us. Again, following on from Joe's theme of achievements, I'd want to look at our local achievements, and there are many. And also some of the challenges to the further rollout of the flu programme and the next steps that we'll be taking in Thames Valley. So just looking at, I mean, this is about, again, a sort of flu version of Joe's timeline. We're like clones, aren't we? We all do the same thing on a slightly different format. So it was in the late 60s that actually we started immunising people in clinical risk groups. And we still immunise children 6 months and over in the clinical risk groups against flu. And I think it's important that that doesn't get lost in this general campaign that we're doing, that actually there are still very particularly vulnerable children out there. So although we're doing this general rollout, don't forget that actually those at risk are still at risk. That hasn't changed, and we still need to be focusing on protecting them. It was in 2012, July 2012, that the JCVI produced their statement on the rollout and the extension of the flu programme, and only a year or so later that we began the rollout. And that was in 13-14, a year none of us will forget, because having just undergone the most significant organisational change I think the NHS has ever seen, we are then presented with, oh, by the way, can you immunise 2- and 3-year-olds against flu, in roll out rotavirus, roll out shingles, and actually stop giving some menacing. And while you're at it, can you achieve these higher targets in the general flu campaign? So as Joe said, that was a challenging year and a difficult year for all of us. But we survived, we did it well, and we've come out to the other end. Following year, 4-year-olds were added, and for those of you in general practice, you've been doing all that work. 15-16, that will continue. There's going to be no change to that. As commissioners, we are now looking at how we can provide for 5- and 6-year-olds in the 15-16 campaign. Provider and setting to be confirmed. So that's, we'll come on to that later, because that's something we're working on at the moment. As I said, one of the things I wanted to look at is what actually makes this programme different. So, and you know, how those differences impact on challenges, and how those differences actually provide opportunities for us in how we deliver the programme. So we'll just skip through a few of those. I think again it's looking at the eligible groups. As I say, keep your eye on the ball with the 6 months to 16-year-olds in the clinical risk groups. They continue to be a priority, we mustn't forget them. And again, we've got this phased implementation of all children 2 to 16 years. That is an awful lot of children. Nationally, that is 750,000 children in each of those age group cohorts. Locally, it's, I think, just a smidgen under 30,000 children in each of those age group cohorts. I was going to multiply that by 15 to get how many children that is locally over it. I can do that sum. The sum's a bit scary at the moment, so I'm going to do the sum on another day when I'm out for a shredded wheat instead. And I would, you know, and you can do the same. You know, you can do the same sum. I was going to say for your practices, but it doesn't actually. You've peaked, so you're okay with that one. I think the other difference is this is an annual immunisation programme, and actually other immunisations programmes for children, we've got the nice schedule, we know what to do when children are missing in, but actually this one is different in that actually we're asking all those children, those 750,000 children in every 1 year age cohort to come back every year for another flu immunisation. So actually that's different, both in workload and actually how people think, our parents think of immunisation, because normally it's a one-off, but we're asking them to bring their children back every year. Looking at some of the opportunities, that's a vast number of people that need immunising. We haven't suddenly miraculously had, you know, an increase in the number of practice nurses or school nurses or health visitors. So actually what it's also provided is actually an opportunity to look at different ways of providing immunisation. Alongside the rollout, and I'm not going to go in details, but I think a lot of you will be aware that there have been pilot schemes going on in schools for immunisation, for the rollout of the children's programme. So one of the differences actually, this involves primary schools. Now, I think if any of you are school nurses, you will be very much used to going into secondary schools, immunising, you know, 14, 15, 16-year-olds, 13-year-olds. But actually, often nurses haven't immunised in primary schools, so that could be a difference that we're faced with. Some of the pilots have used pharmacies. Now again, in Thames Valley, we've started offering general flu immunisation in pharmacies, but we haven't extended that to people under the age of 18. But that might be something areas have got to think about because of this need for increased capacity. Also, it's about using the skill mix and actually who can give this immunisation. And certainly some areas have used healthcare assistants. Again, healthcare assistants are used in some practices for giving flu jabs to sort of uncomplicated adults. Generally not used for immunising children, and Sarah will correct me on any RCN guidance on that, so I'm not going to go down that route, particularly when she's in headmistress mode. Also, some of them have used models of self-administration. As we'll come on to, this is an intranasal vaccine that we're generally using for this programme. So actually that gives an opportunity for trying that innovative approach with variable results. But as I say, I'm not going to go into details of the pilots this year. One of the big differences was the vaccine that we were using. The JCVI recommendation was to use the live attenuated influenza vaccine, which is an intranasal vaccine. It was a trivalent vaccine in the first year. It's now a quadrivalent vaccine. That's what was in it last year, and we'll come on to a little bit later about why that wasn't effective. Actually, I took the opportunity to look at the WHO website last night, actually, when I was doing my final preparations for this, because I quite like the names they always give them, and I'm, you know, waiting for Grimsby and Scunthorpe to come up, but they never do. Next year, we've got Texas is transforming into Switzerland, and we will no longer have Massachusetts, but we will have Phuket. So it's still rather exotic and rather pleasant. So I still want to put in a campaign for getting a good British northern name in there. But that's my personal, and I know many of you in the room won't share that. I think the other thing about the vaccine is that short shelf life. So it does mean that there's a window of opportunity for delivering this vaccine. Some vaccine is sort of still within date in January and February, but on the whole, the majority of the vaccine has got a shelf life that will expire sometime just pre-Christmas. So it does mean that we need to get most kids immunised before Christmas, which actually is good practice because we want people immunised as soon as possible anyway. So we haven't manipulated the shelf life for that reason, but it does push us in that direction. Again, this intranasal vaccine, it's a live vaccine, it's not suitable for all children. There was obviously quite strict guidance on egg allergic children. If you've read the latest JCVI minutes, that is changing slightly, but I'm not going to preempt. I know the Sniffles 2 study has been discussed later on the programme, so obviously I'll leave it to that to go into the detail. Also, obviously, children with immunosuppression, and we've had the issue with porcine gelatin, which is one of the components of the vaccine. It's a stabiliser in the vaccine. They did try other stabilisers, but this was the most effective one. So there's no likelihood in the immediate future that will be changing. So it is something that is there that we will be working with. I'm not going to go into any detail, but any questions come up, we'll try and answer. Joe, you found a much better picture of a child being immunised. But what I love about this one is the blue marigolds, because I know you all wear blue marigolds when giving immunisations. I think it's an essential part of the nursing kit is a pair of blue marigolds. As has already been, Joe's already alluded to, another difference about this programme is we're protecting individual children, so we're stopping those nasty outbreaks of flu in schools that always occur just before Christmas when you're at your busiest or when work's busy and you've got to take time off or you can't get the Christmas shopping done and the school's closed. So we are protecting those children, individual children, and preventing outbreaks in school. But it's also children are the super spreaders, so we're also stopping flu being transmitted to other parts of the population and to, quite vulnerable people in the community. And so that is a part of the programme, and I think everyone's very open about that. Some people do find that quite challenging that we're immunising children to get benefit for the whole population, but we're also getting benefit for those individual children and also for their school and home communities. Someone's got a rumple. As I say, JCVI came out in July 2012. We're using a live attenuated vaccine because it is a better vaccine in children, gives a better immune response in children. So it is, for the programme to be effective, we do need to be using the live attenuated vaccine wherever possible. As I said, we're going to be ultimately immunising everyone from 2 to less than 17 and giving that indirect protection to adults. And actually that indirect protection to adults is one of the things that's factored in when you're looking at the cost effectiveness, because no matter how effective a vaccine is, for us to commit valuable NHS resources to it, it also has to be cost effective. And however unpalatable that is, particularly now when I think that's particularly pertinent when we're talking about the Men B, which I think we're all receiving a lot of queries on that from anxious parents who'd like their children immunised. When we're implementing national programmes, we do need to look at cost effectiveness so that the limited resources are spent very wisely. And that does factor in the fact that we're getting additional population protection. So our achievements. So again, I'm focusing on achievements in Thames Valley and the different things we've done over the year that are good. So this is our, Joe, my numbers are slightly different to yours, only by about 0.1 or 2 here for the England ones, but I don't know, anyway, not significant if you put confidence intervals on it. Looking at the 2, 3 and 4-year-olds in Thames Valley, as you can see, we are generally performing about 4 to 6% above the national average, which is absolutely brilliant. I am competitive by nature, so I do like to see that happening, so well done. That I don't have to face embarrassment when I go to national or local meetings. And even though sometimes we're not meeting targets, I can say, oh, but we're the best in the south of England, which is always pleasing to do, so thank you for that. As you can see, there's been a slight, we'll look at this in a little bit more detail because I've gone into graph mode after this. In the first year, we were doing better in 2-year-olds and 3-year-olds. That has reversed. My theory, my rationale for that is actually the 2-year-olds were immunised last year, so they're used to being done, so they've gone back for it a second year. That's a good sign, because hopefully that will continue, although it isn't, so we'll come on to that. And obviously it was the first year the 2-year-olds had been invited. If we go on to the 4-year-olds, actually they were immunised last year, but they didn't come back this year. But where have they gone? They've gone to school, and they've gone to preschool, and I think that is probably the thing that's impacting on the uptake in the 4-year-olds. But just soak it in, we're well above England's average. As I say, I like going into graph mode. The hieroglyphics at the bottom are the codes for the PCTs. And I've forgotten to bring the key to the code, but I do have it on my laptop if anyone's particularly interested. And this is just looking at the variation between our PCTs in the area. As you can see, CCGs, oh God, retro. They'll be coming back. I mean, 5 years' time I'll be standing up here saying, right, PCTs. As we can see, there's been a fall in all CCGs apart from 10T, and I'll disclose 10T later, so I'll keep, unless you know who 10T is, I'll keep you on tenterhooks about that one. So, as we can see, can you see over there actually? I've just punched on my laundry. They've done better this year. All the others have fallen slightly, and as you can see, that just replicates the national and the regional picture. This is the 3-year-olds. Actually, in the 3-year-olds, we've had 6 of our 10 CCGs have actually done better this year, and again, you can see, actually I'll use the points because they did so well. 10T has had a nice big jump compared to everybody else, and again, I'm sure Liz and Julie are smiling at that one. They know who 10T is. And this is the variation in our 4-year-olds between CCGs. So overall, most CCGs are doing very well and achieving at least 40% level. We also look at variation between practices. So these are the names of our CCGs along the bottom. The numbers in brackets are actually the number of practices in that CCG, so it just gives you a feel for what we're dealing with. I've gone off piste here actually, I hope I've not missed anything. As you can see, there's some like Newbury District are actually, although it's a small CCG, it's quite tight. They're achieving well, and all the practices they're achieving well. And I think that's just geographically, it's not quite as diverse an area as some of the other areas that we deal with. If we look at an area like Slough, their average is actually pretty low. But even so, even though it's pretty low, there is a practice there achieving over 80% uptake in their children. And actually see across the board, there isn't a CCG in the area where someone hasn't achieved 60% uptake. So I think the message from that is, actually, no matter where you're located, if the right systems are in place, it's achievable. Oh, now, fancy charts. Thank you, Oxford Academic Health Science Network. This is where you go from area team, all we've got is Microsoft Excel to produce our charts, an Academic Health Science Network when we've got access to fancy software so we produce nice funnel plots. So thank you for the Health Science Network for allowing me to show these. Now these are the 2-year-olds in 13-14, so this is last year, sorry, the 2-year-olds last year. And as you can see, there's a wide, every little dot represents a practice in the Thames Valley. So that's why they're not named, because it would look a bit of a mess. As you can see, there was some there below 10% uptake. And that's one of the things we looked at this year, actually. Why was that the case? Was it just the wrong code coming into the system? Had they forgotten to invite the children? There could be 101 reasons for that, and it is something that we looked into. What the blue lines, the blue dotty lines are in the funnel is that showing whether that practice falls within an expected range, a range you would expect for the size of the practice. It's a simple version of explaining it. So it's practice population of children along the bottom. So if your practice falls within the funnel, then actually we can't say that you're doing any better or worse compared to the average than we'd expect from normal statistical variation. The ones above are doing pretty well. The ones below are actually not achieving so well. So this is the 3-year-olds. So this is essentially the same group of children, but one's immunised the following year. As you can see, we've at least got rid of those really low ones in the bottom. And I have the eye of faith at the moment, and to me it all looks like it's shifted up a bit, but I haven't looked at the detail of our local data that much yet to be able to say that. What I wanted to highlight is some work we've done locally with special schools. Now this is going back to the need to make sure those children in risk groups are immunised. I think we've been plugging away the message about the relative risk of death from the different types of risk group for a number of years now locally. And you'll remember that neurological disease is one of those. And actually there's certain special schools, some special schools are mainly behavioural problems, but there are some special schools where the majority of the children have a long-term neurological condition or other medical condition, or often a combination of both, and actually have multiple risk factors. For that reason, both in Berkshire and Oxfordshire in past years, we started immunising in special schools. I think in Berkshire, which is where I came from, it was precipitated by the fact that there was actually, during the pandemic, there were deaths in children in special schools. And from then on, we gradually built up an immunisation service within the schools. So we're pleased to say for the first time this year, we offered that service to all the special schools across Thames Valley that had a high proportion of children in the clinical risk groups. I think the thing to point out is that actually one Oxfordshire school we weren't able to get into I think for those of you who work in the area, I think you'll know that actually accommodating all these things within the school day is increasingly challenging, because the school is already trying to fit more into a small area of time. And I think actually that's relevant when we're looking to implement the main programme. That it's one of the discussions we're going to have locally is that working with the schools to ensure they'll accept the programme in school.
Chris, do you want to be right up to the mic just while the noise is there? Just so
right, is that okay? So really this was just again to emphasise the risk groups, to look at a piece of, I think, really good work that's gone on in Thames Valley around immunising children in special schools. And as you can see, Berkshire's where it's been operated the longest, and as you can see we're immunising about 45% of the school cohort in those schools. You've got to remember that some still choose to go to their GP, and that's fine. So overall now we're getting about 50% uptake in those risk groups, which I think is real progress. Again, partnership working, I think, is one of the keys to what we do. I've already mentioned the Oxford Academic Health Science Network, and I will say I think you've got a stand outside at lunchtime?
Yep.
Yeah. So Julie and Liz at the back will have a stand outside. The Health Science Network have a children's stream of work, and one of the projects they undertook this year, and I think will be hopefully continuing next year, is helping us to improve uptake of childhood immunisation for the flu programme. So they work with both low and high uptake practices. From the high performing practices, they developed a good practice guide. They also did outreach work both in public settings and with health professionals, in that they presented to a group of GPs at Slough at one of their protected sessions. They identified some of the barriers to immunisation, and actually identified quite a low awareness in some areas about the flu programme in children. So I think that's something we've all got to take on board, whether you be working at the practice level or the commissioner level, that actually not everyone is aware of this, that we think they might be. We worked heavily with local authorities around publicity, and also the CCGs, and I would say that 10T CCG were very good in that. And actually I should reveal 10T is actually Slough, who actually has one of the worst uptakes in the area. It was one of the areas that Julie and Liz from the Science Network targeted, and I think it has shown some benefits from that perspective. Communications, I think, worked well this year. The National Communications Campaign, that's where I enter into my non-comfort zone. Of all the people mentioned on there, I have heard of Peter Andre, but that's only because my guilty pleasure is reading Hello magazine when I get my hair cut. But the others, I have no idea who they are. The other reason it's outside is this use of social media and thunderclap, namely. I'll do a joke now. Who's heard of thunderclap? Phew, I am not a man. I think it's a way of magnifying social media and getting it out there, but I'm glad I'm not on my own in this. And I do have a definition if anyone wants it, but it was something I was introduced to this year, as I was Emily MacDonough. Locally, we made children one of our theme press releases, and that did get some uptake from the local media. We produced locally information specific for children and had that translated into the 3 languages that are most used locally. And again, work with our local authorities and public health teams, getting things out through their routes, and that's, I mean, the division of public health has been challenging, but one of the benefits is actually we've now got public health people in local authorities, so accessing those channels through children's centres and schools has actually been facilitated by them. So challenges to deliver the programme. I think we've had we alluded to some of the challenges around the vaccine. I think, in the first year this was actually, it did cause quite a lot of anxiety among nurses because it was so different. But I think, with time that calms down, but, the porcine gelatin might still prove a challenge. The procurement process is quite a challenge for us, because this is potentially such a huge programme when it's rolled out. We can't just have a little chat with our local school nursing providers and say, actually, can you do this? Can we add it to your contract? Because it's going to be such high value, we've had to go through quite a major procurement process that we've been supported nationally with. And I put the general election on that because when general elections come on, they put a, I wouldn't say a dampener on everything, that's not quite the right phrase, but they can slow down decision-making processes around things like contracts. We've talked about the workforce, enormous programme, enormous workforce implications. I was just going to briefly mention vaccine efficacy, because I think we're all aware of the publicity around that this year, that, you know, from time to time, I'm sure it's going to happen, the viruses are drifting, you are going to get years like this, but obviously we've got to be aware in the back of our minds that could impact on public perceptions, so you get things in the newspapers that, you know, raise that in the public's mind, and not always using helpful language. So it might be a challenge for us next year to have to face that, you know, what we've thrown back at us was the vaccine didn't work last year. Can you guarantee it's going to work this year for me? Just mention Switzerland and Phuket and they'll be impressed. So from our perspective, our next steps as an area team, if I can call ourselves out, are securing the providers for the 5 and 6 year olds. So we're, with the help of the national support team, going through that procurement process. And we hope we'll have a decision made by April, May. I think uptake ambitions for this programme are going to be set at a minimum of 40%, and that is across all localities. So you can't say, actually, our 35% in Slough is compensated because everyone in Wokingham loves the vaccine. So we'd be aiming for 40, and actually we're not that far off, so what we should be aiming for is that upper target of 60%, and I think that data's shown that actually, as a result of your hard work, that is achievable. We will be continuing our partnership with the Oxford Academic Health Science Network, details of that to be confirmed, and again we'll continue working in partnership with primary care and CCGs and local authorities. So that's all I wanted to say. Thank you.